from dying. An emphasis is on personal medical care rather than on public health interventions. Next slide. Now, but the good news is this, that our government in Nigeria at all levels, national, state, and local government are trying to do something to put things right. There are some reforms in health sector. They are modifying and revitalizing the primary health care. Several remedial strategies are evolving and goals are being set. Let's look at the major causes of death in low-income countries in Southeast Asia and Africa. You see infectious diseases, 45%, and that can be prevented. You see almost half of that pie made up of diseases that can be prevented. Next slide. Leading causes of death global, still infectious diseases taking a bigger pie, and among the affluent people, cardiovascular diseases. Next slide. But what are the biggest killers of the poor? The biggest killers, can you see that? Malaria. I'm sorry, the labels are not visible here. Malaria is 39.42%, accounts for 39.42% of deaths in developing countries. And that is applicable to Nigeria and applicable to Cross River State. So these are the biggest killers of the poor: malaria, HIV/AIDS, acute respiratory infections, maternal and perinatal conditions, diarrheal diseases, and other causes. These are all things you can prevent. Next one. Now, I brought this. This is the only depressing statistics I'll show you. I promise I won't show you anymore. Maternal mortality rate. Can you see that? It's quite high, and that obtains in Nigeria and in Cross River State. 1 in 13 women die of causes related to pregnancy. That's high. As much as 35% of women experience first pregnancies at 19. Not more than 60% of women receive prenatal care. Next one. Only 31% of deliveries take place in health facilities. Only 36% of women are in the workforce. Only 35% childbirths are attended by trained personnel. Life expectancy for women is 52 years. We are even doing better than the men, because generally the average is 40-something in Nigeria right now, the life expectancy. And I think for men it's lower. I don't know why. Infant mortality rate is 126 per 1,000 live births, was in 1996, and 138 per 1,000 births in 2009. So it means it's getting worse. Then under 5 mortality is 126 per 1,000 live births in 1996, and 86 per 1,000 live births in 2009. Access to sanitation, 32%, urban and rural. Access to safe water, 58%, in spite of all the agencies and all that we have, 58%. Now, government has tried to do a lot to solve all these problems, and there have been policies and policies I'm unable to give, to count. We are still counting. These are some of the policies. It fills a slide. I'm not going to read them. All these policies exist. The next slide, also more policies. The next slide, more policies. The next slide, more policies. The next slide, more policies. So it is not lack of policies that is the problem. It is inability to implement these policies properly and coordinate them. Recently, some diseases were grouped together and called neglected tropical diseases because they've been neglected. And these are the bigger killers, the biggest killers of the poor. And I've listed them all there. Next slide. And government decided to tackle this by placing an integrated approach in the implementation of programs for NTDs. Promote it, it's cost effective, you address the high burden due to these diseases amidst inadequate resources appropriated for their control. And so the NTD policy is in place also. It's called the National Policy on Neglected Tropical Diseases, and aims at the development and implementation of programs that will control or eradicate or eliminate or manage these groups of diseases. We have to link whatever we are doing to the MDGs. the Efik National Association, whatever you're coming to do in Nigeria, in Cross River State, has to be linked to MDGs, because this is the most focused initiative we can see right now. And countries are being assessed according to how far they've gone in achieving the objectives of the MDGs. And next slide. It's quite interesting that health is central to the Millennium Development Goals. That's the MDGs. It's a central thing there. And it's central because it's central to poverty reduction and development. And I told you that there's a cyclical relationship between poverty and health. You are poor when you are unhealthy, and you are poorer when you are unhealthy. Next slide. The goals, I'm sure you are all familiar with MDG goals. Goal 4 has to do with reducing child mortality. I'm sure one of your objectives in coming to Cross River to do your outreach will be that. Goal 5, to improve maternal health. I'm sure you want to address that. Number 6, to combat HIV/AIDS, malaria, and other diseases. And 7, to ensure environmental sustainability, including reducing by half the proportion of people without sustainable access to safe drinking water. All these goals are directly related to health. The ones that are closely related to health, goals 1 and 8. Goals 1 is to eradicate extreme poverty and hunger, and goal 8 to develop a global partnership for development. And having direct impact, not relationship now, direct impact to achieve universal primary education and to empower women. Now, before these MDGs, the Millennium Development Goals, we had all kinds of initiatives in Nigeria put together to reduce poverty, to improve health. And they are all listed here. You are familiar with all these things. Operation Feed the Nation, community banks, family support program, National Directorate of Employment, People's Bank, and so on and so forth. 7-point agenda, national economic empowerment, and who is laughing? 7-point agenda. One driver that carried me in Abuja said once, he said, "Madam, this 7-point agenda, why don't they just have 1 point? And that is NEPA, fixing NEPA." Also, we have closely linked to the MDGs, the needs document, which is like the MDGs. So the needs at the national level, next one, the seats at the state level, and the leads at the local government level. It's a homegrown poverty reduction strategy, and Nigeria's plan for prosperity, Nigeria's vision for becoming the largest and strongest economy in Africa, and a key player in the world economy. And the strategy seeks to reform government and its institutions, as well as grow the private sector. Next slide. Next one. Okay. I like this quotation because I took it directly from the needs document. And it says, poverty reduction is the most difficult challenge facing Nigeria and its people, and the greatest obstacle to pursuit of sustainable socio-economic growth. The poverty rate in Nigeria increased from 27% in 1980 to 66% in 1996. And by 1999, it was estimated that more than 70% of Nigerians lived in poverty. I don't like such statistics, but I picked this directly from a government document, so I think it is correct. Next one. I think let's move on. I want to try and keep to 12 minutes. Now, let's get back to this social definition of health. If you enter a community as you are coming now to do the medical outreach, and you ask the community members, what are your problems? What are the problems needing immediate solution? Even if you come with 100 surgeons, they are still going to tell you the problems that are their problems. And there will be a mix of problems. They can even tell you, "Madam, please go." Tell you, "Madam, please go first when we are waiting for the bridge to be built before you come back." Or go, "We want our roads to be fixed, then you can come back." So you can go with all these, all your medical kits and everything. If you are not able to address, even to a very small extent, the other problems facing the communities, then whatever you are doing will not be sustainable, and it will not be appreciated by them. So as you are coming along, please, you'll be ready to listen to other problems of these communities. You treat them fine, but you listen to what they have to say. And they will give you a mix of problems cutting across sector barriers. They will give you their problems of water, malaria, diabetes, hypertension, backache, eye problems, bad road, no jobs, and so on. As if that was your making, but they will tell you they have no jobs. And these are the problems the communities would like to see solved. So even if you cannot solve any, at least you listen to them and promise them that you get whichever sector is supposed to solve that problem to come and do something about it. Now, in developing countries, getting back to health, about 80% of all diseases result from a combination of poor hygiene, contaminated water, poor sanitation. Available data show that only a handful of preventable infectious diseases cause much of the mortality and morbidity in communities in Africa. What I'm saying here is that you can come and treat what is manifesting. You will have to come back the next year to treat the same number, and another year to treat the same number. If you don't address those factors that are determinants. I often smile when I hear people doing deworming. Madam Senator, you are aware, there are all kinds of pet programs. They go to a school and deworm children. They deworm children, there are no sanitation facilities, so the children just, the worms are sent out to the environment and they get more infected. A student of mine did a project on that and studied the worm load before deworming. 1 week after, 2 weeks after, of course, the thing just went back. It went down and then up again, and stayed there for another person to come and do another deworming. So the intervention there would have been to make sure that the primary school had water. The primary school had toilet facilities. The sanitation in the school was okay. Then you can have no peak anymore, the peak going down and coming, or instead of having a plateau in the graph. But we keep having these dewormings, and it's like a waste of money and time. And you are the children who have had no meal in the morning, and it's so stressful to them, they might even collapse. So, malaria, HIV/AIDS, tuberculosis, respiratory infections, and all that stand out as key killers of the poor. This global picture is replicable in our communities in Cross River State. So you may want to, in future, try to put in interventions that will tackle these determinants rather than just come and give drugs and do surgery. So promotion of health is not simply treatment of illness. I think our leaders should know this. I'm sure the senator will tell them this whenever she discusses with them. Promotion of health is not just treatment of illness, but it's an investment in a nation. When you are taking care of the health of the people, you are investing in that nation, because you are going to have a brighter workforce, people who are alert, children who are intelligent. So it's important for any government to determine which investments and strategies produce the largest population health gains. Which investments and strategies help to reduce health inequities and are in line with human rights. Which investments contribute to economic and social development in an equitable and sustainable manner and result in high health returns. Any government that does this and focuses on these investments will have its economy improve. Because a lot is lost because of ill health. In our communities in Cross River State, as in the whole nation, people pay what we call malaria tax. That's the money you spend in treating malaria in your household. If you calculate that amount of money, it's quite substantial. It's a substantial portion of your salary. Then you can talk of other diseases and add up all the taxes you are paying to these diseases. Next slide, please. So what I'm saying in effect is this, that we should always adopt a cost-effective strategy. What is happening now in our countries is that a lot of expenditure on health is towards the end. You can see this continuum: good health, exposure, disease, and death. Most of the expenditure in Nigeria, in other countries too, in health, is around that disease and death area, where they are trying to prevent people from dying. What we call social solutions, so that the child will not dehydrate and die. You know, invest in that. You invest in things that will stop people from dying. But the best point to intervene, which is cost effective, is between good health and exposure. That is preventing exposure. I think the Efik National Association should take this into consideration when you are designing your packages, which we are bringing back. Make sure that you have interventions that are in that area, plenty, rather than on the other side. This is the People's Paradise. I thought I should remind you. That's where it's located for the younger ones. That's Nigeria, and that's where our great state is, the People's Paradise. For malaria, what I was saying about trying to prevent is so simple. It's not rocket science. Very simple. Source reduction, destruction of breeding sites of mosquitoes, and removal of items holding water. In Europe, in the 19th, I think it was in the 16th century, there was plague. And how did they handle it? They just effected sanitation, and the thing just reduced. Sanitation only, and it reduced. Then prevention of contact between mosquito and man, bed nets and all that. I think we'll skip this, go on. Destruction of the vector, treatment, go on. So it's, again, it's very difficult to just come and say you are doing health interventions. You have to add other interventions to it. So it's important that the Efik National Association in their medical outreach prepare to work with government at all levels and work with other partners, non-governmental organizations, not non-governmental individuals, not NGIs, not governmental development organizations, and existing community groups, the community-based organizations, the private sector, and so on. And you need to obtain appropriate permission from all levels, otherwise you'll have some little resistance. So, closing in on your medical mission, I think you should try to fill the gap by collaborating with implementers of ongoing health programs. The health programs that are already on, you just get to the program coordinators and try and work with them. Then whatever you do, you strengthen the health system. That's work within it, but not outside it. Don't come and set up a parallel intervention. I'm making a suggestion that your outreach is good. You carry out your outreach and treat those that are already ill, but at the same time try and provide portable sources of water in schools and markets and wherever you have large gatherings of people. You may want to charge your members to remember their villages, and maybe when next they go, they should take a look at their villages, find out whether there's enough water supply coverage, particularly in the schools, and try and do something. It's not very expensive to put in a borehole. So you may act collectively, but also act individually. Give a charge to your members. And you can donate equipment, sorry, that is hidden. I know that in Calabar, we do not have a dialysis machine. There is no mammography. If you have any kidney problem, then they have to carry you to, I don't know where the next person, Uyo or Port Harcourt or somewhere. And God help you that you survive the good road. I mean the bad road, I mean. Now, the key steps: you take permission from the government, permission from leaders of the community, you identify your partners, identify operating base in each location like a hospital, and notify the officer in charge, and prepare all your items. Next one. So, sorry, I had tried to make it some teams for you, but I think this may not, you may have your own idea. Go on, next one. So these are the partners. Among the NGDOs, you have Medical Women's Association, you have Youth Care, Grado, Sickle Cell Association. Among the CBOs, don't forget the age grades, they are very useful. Women's groups, faith-based organizations, Parents Teachers Association, and then private establishments, banks, and so on. Now, the message I want you to take from this address, I know I'm spending more than 12 minutes I'm allocated, is this. There is a Canadian saying around health. When you see a child drowning, you save the child. You see another child drowning, and you save that child. You can continue saving drowning children and forget to look for the person who is throwing the children into the water. So what I'm saying is this. It's good to have an outreach, go out there, treat those that are sick already, but also look for the, okay, I'm rounding up. Also look for the determinants of the situations which we are looking at and deal with the determinants. I just want to entice you with some pictures from Cross River State, the ranch, and then the carnival. Thank you for listening.
Ladies and gentlemen, another round of applause for Professor. There's no gainsaying that that is a very, very intelligent woman. She is the current Vice Chancellor of the Federal University Lafayette Nasarawa, a fellow of the Sixbox Seminar, Session 319, Nigerian Society for Parasitology, and the Nigerian Academy of Science. Professor Braid was a zonal facilitator, Nigerian Guinea Woman Eradication Program 1998 to 1999. The member of the Mestizen Expert Committee 2003 to 2006, chairman of the African Program for Onchocerciasis. Oh, you know me, ladies and gentlemen, a round of applause for the professor. If I stand here to read her credentials, they will not go home tonight. Please, a round of applause for her. A round of applause for her. A round of applause for her, please. Thank you, ma'am. Thank you. Thank you. Ladies and gentlemen, like I said, time is fast spent. Please, somebody will be facilitating each table according to your turn to go get something to eat. It's pretty late. It's part of the wellness we are talking about. We shouldn't eat after 7 o'clock again. But ladies and gentlemen, I'll whet the appetite of those that have come to watch the beautiful display of the Efik people by inviting the youth cultural dance. Ladies and gentlemen, a round of applause for them as they come out. A round of applause for them as they come out. Ladies and gentlemen, if you would go back to your seats, come on, we are all seated. Seated, please. We are all seated, please. Thank you. Thank you. Ladies and gentlemen, a round of applause for that, please. Thank you. Thank you.